Welcome to Truth Be Told. I am your host, Pierre Kasongo. Today, I have another exclusive guest on my podcast. She is a board-certified internist and Harvard-trained geriatrician who exclusively takes care of patients aged 65 and above who currently practices in central Wisconsin. She has a passion for the care of older adults, as well as educating her patients, their families, and other doctors and care providers on how to best take care of the aging population. Listeners and viewers, it is my pleasure to welcome to Truth Be Told, Dr. Aanu Abiola. Dr. Abiola, welcome to Truth Be Told.
Thank you so much, Pierre. It's good to see you, and thank you for having me on your podcast. I'm excited.
For those who don't know what a geriatrician, just tell us a little bit, just like what exactly that you do.
Okay. So a geriatrician is, let me start from the beginning. I'm a geriatrician, but I also am an internist. So if we kind of go through kind of like the training in medical school or medical training, so you start off as a medical student and you do your 4 years of just general medical um, training, and then you become a medical doctor. So that doesn't allow you to practice independently or practice at all. You really need a board certification or at least additional training in a specialty. So for me, I chose internal medicine to be my specialty, and from there, I then subspecialized in internal medicine. So when we think about internal medicine, it really is a hub of many of the specialties we think of. So when we're thinking about like cardiologists and nephrologists, and if we're thinking about endocrinologists, all these other specialties, rheumatologists, they all trained in internal medicine and then subspecialized in their field. So for me, my subspecialty is geriatrics, and I've really focused on that, caring for older adults. So with the care of older adults, some people say, well, you're just taking care of an older person. Yes, that's true, but in a lot of ways, it's also caring for things that are more specific to older adults. So to use the same paintbrush that or practice methods that we would use on a 35-year-old, on the same as a 95-year-old, it's not going to work and it's probably going to turn out poorly. So me, I have a specialty where I'm able to tailor my care specifically for older adults. If it means decreasing medications, if it means streamlining care plans, if it means making sure families are all on the same page, if it means changing how we're deciding we're going to move forward with treatment or not treatment. And a lot of it does revolve around educating patients and families, which I've mentioned previously as something. When I think about geriatrics, I think of it as a very well-rounded specialty. It's a specialty. Yes, we take care of older adults, but really, a lot of the principles we apply to older adults can be applied to younger populations or other populations. The reason why it's so important that we do take extra time and extra pause with older adults is because they do require a little bit more specialized and thoughtful care. The other thing is because when older adults, when we do take care of our older adults, there are a lot of health benefits for them. And then when we don't take care of them to the best of our ability, they do not bounce back as well. So it can be really a quality of care issue, a life-saving issue. There can be a lot of morbidity and mortality benefit by taking care of them specialized. It would be similar to saying, why do we need pediatricians, right? They're still humans. They're just younger humans, but they have different care needs. Their bodies are different. Their physiology is different. The way their bodies handle medications and the illnesses that they have are different than just somebody who's 35. And so I always try to tell people like it is important to have pediatricians the same way it's important to have like just a general practitioner, the same way it's important to have geriatricians, and it's important to have a practitioner. One other thing is that I get to spend a lot more time with my patients than most other doctors, and that's kind of a roundabout way of describing geriatrics. I always say if somebody sees me in action, they'll understand what I do.
Kind of
Yeah,
reminds me of the the song "Wake Up Everybody" by Harold Melvin and the Blue Notes. And wake up everybody. That's actually the part of the song that, just let me see, that goes, "Wake up all the doctors, make the old people well. They're the ones who suffer and catch all the hell. So, but they don't have so very long before the judgment day. So won't you make them happy before they pass away?" That kind of care just kind of reminded me of you, and that it's just a beautiful song, and that thought I was associating with the care of the of of a geriatrics, and that song, they kind of intertwined, and it's just so beautiful how we need to look after our older people,
Mhm. Yeah. And I think it's like when we think about older adults, people think like, oh, like there's these older people, but like older adults, and it's 65 and above, which when I know, we're like, oh gosh, we're getting old, but like it's not that far away, right? It's not that far away till
Hmm.
that we're that old. And it's in my mind, 65 is actually quite young. And I'm pretty sure we all have a 65 or above person in our lives who we care about and want to be healthy, right? And
Absolutely,
making
yes.
sure that the person who is taking care of them knows exactly the best way to do it is so important, right? It's our parents, it's our grandparents, it's our aunts, uncles, it's our mentors. These are all people, and it's very important that we are taking care of them. And I always think there's a very interesting like guy, especially in like North American culture and even in other cultures, the way we think about older adults is a little bit, it's skewed, but it's compartmentalized. And so it's like we compartmentalize them into, oh, well, you're too old to do X. But at the same time, you're young enough to run our countries. Right?
That
You're
that
young enough, you're young enough to sit in positions
yeah.
that determine how the country
Hmm.
runs. But like my neighbor who is 70 down the street is
Uh-huh.
an old man or something like that. And then we think about them very differently. So it's like it's very interesting how we compartmentalize them. So they're important enough to be in these positions where they I mean they run everything, but at the same time, like we need to take care of them. If we're going to put them in those positions, we have to make sure that they're healthy, and we have to make sure that these people are like able to be at their full potential.
Because
And
there was
anyway,
even one person with whom I had a discussion with me at that. He was even asking me about that question. Like he was even telling me, "Oh, I'm 60 years old, but like, oh, I can't do this." That's just like,
yeah,
oh, come on, like, just
yeah,
no, no. Like I told him, like, I'm not ageist. I'm not into that. Like, I
yeah.
went into going into a yoga session. I And then the instructor comes in. It's actually an older. It's actually an old. The guy that walks in, sits down, does all these yoga positions. Then at one point, puts his feet behind his his
Okay.
head. Just like, oh, I'm not saying anything after that. Or I have, or even my personal trainer at the gym is actually 60 years old. This guy's ripped. I'm and I think like we've sometimes fail to recognize that age, like it means like, being older means wisdom.
Most of the time.
Yeah, most of the
If
time.
we're lucky, yes.
Yeah, like
Yeah.
rather than just being like, oh, you should recognize that like with age, it's just with a lot. Hopefully, it's wisdom, intelligence, because they've seen because older the people have seen a lot of history. They've seen a lot of news that has happened in the world. They've,
And you know, I always do mention that. And so, like, even though we do have to consider age when we do consider how, like, especially from a medical perspective, how our patients function and patients, even their memory and all these other things, it is not a monolith. Older adults are probably the most diverse population. When we think about the age span, 65 and above, we have patients, I have patients who are like 106. So you could be my patient for 40 years. That's 40 years. That's bigger than most like spans that most people take care of. And so me at 65 and me at 95 are very different people, but we're both in the geriatric population. And so making sure we know how to adapt to that and knowing that it's not one brush stroke for everybody is really one of the biggest crux when I care for my patients. And so it gives me a lot of freedom to individualize their care plans and all those kind of things.
yeah.
Yeah.
And speaking of individualizing their care plans, you were mentioning I was actually watching like some of the posts that you had put about the 5 M's
Yeah.
of geriatrics. One of them was what matters most.
Correct. Yeah.
And what is the one that really fascinated me was what are the patient's goals? Like, do
Correct.
you think that question is often asked, or is it even asked enough?
I think that it's often not asked, and I don't think it's asked enough. And I think that, so first thing, geriatricians are in a very low supply. I'll only speak from a American perspective since that's where I practice, but as far as I know, it does also apply to Canada as well. So in the whole of the United States, millions and millions and millions and millions of people live here. There are 7,000 board certified geriatricians, give or take, less than 8,000. Okay. So there's 8,000 people who have medical degrees, MD, DO degrees, who have the tools and the knowledge to take care of all these people. We do have some auxiliary people. There's geriatric nurses and nurse practitioners, and these other people who do have training as well, but to the degree of a doctor, 8,000 or less. Okay. So there are not that many people who have training to understand the importance of asking that question. Okay. And the biggest thing about that, what matters most question, is the fact that that the answer to that question can change throughout your lifespan. And it should change throughout your lifespan, right? And so that's why it should be asked, not just asked, but asked often. It's really a checkpoint so we know what we want to continue doing, what we want to stop doing, and how we want to change what we're doing currently. And so I think that's like a great question. And I think more physicians, more patients' families need to ask that question to themselves and even have the discussion with whoever's helping to take care of them.
And the you just brought up an alarming statistic, which was that this was only what like 7,000 to 8,000 geriatrician in the United States.
Yeah.
Meanwhile, what's the population of of citizens age 65 and over. I mean,
Uh,
that's pretty like we don't have those statistics right in front of us, but that's alarmingly low.
it's alarmingly low. So I can pull them up. So it's changing rapidly. So the proportion of older adults age 65 and above is alarming, not alarmingly high. It's increasing over time. But
Mm-hmm.
the disproportion, as you mentioned, is alarming.
Yeah.
Absolutely. And for that reason, it's so important that me as a geriatrician, not just being a doctor, but also being an educator for my, like I said, for my colleagues, for my patients, so they have more
Mm-hmm.
empowerment and understanding of their care and for their families. And so it's I let me just very quickly look to see about the geriatric population currently. I don't want to give you incorrect statistics.
Yeah, because it's just mind-boggling how low of statistics, just 7 to 8,000, like for because I know that the population of the United States is about what 330 million,
Somewhere in
around
that range.
hovering around that number, and I and, and I don't have the statistic for like each age
Right.
class,
Yeah.
but but I do know that if there's going to be a geriatrician, like 7,000 out, that's not even 10%. I don't
Yeah.
even think that's even a 1%.
So I just looked up and I was 50 million was the number in my mind because that's kind of what I was thinking, but that number changes. So I'm looking and it says approximately 54 million adults in the United States are over the age of 65 and above. So 50 million older adults are over the age of 65 and above, and there's less than 8,000 specialists for their care. Okay.
That's
So that's the landscape in which we live and we practice.
Yeah, those senior citizens are have like are either going to have to travel a ridiculous distance
Mhm.
just to find that geriatricians to look after them, or
Right.
I don't
Uh,
know.
the alternative is that they have a non-board certified person. They could in like whatever primary care specialty who still has very good knowledge or understanding of it. And I always tell people it's not enough to just take care of older adults. People say, "Oh, I take care of patients age 65 and above all the time. I'm an internist. I'm fine." But that's not enough because just because you take care of them doesn't mean you take care of them well, right? Quantity and quality are not the same thing. And so
No,
I
they're
always,
not.
I always try when people just say, well, I take care of older adults all the time. It's just like, but how well do you? What are the principles you're using to determine how you're making your decisions about somebody that age? And most people can't answer that question because they've never really gone through like training, and I don't expect them to. And I also, that's why I don't expect them to be asking that question, what is the goal of care? Because you were never trained to. That wasn't part of your
And
training.
another word uh, that you've kept saying over and over just those few minutes ago: care, care, as well as quality of care. It's already one thing to just say, as like in your specialty, to just say, well, just as a direction, this is what you do, this is what you do to your patient, but you also have to make sure that you give them that quality of care,
Yeah.
that make sure that they're well. And that kind of takes me to some other AMs that you were featuring. Like, for some reason, when I was thinking about those five M's, I was just wondering. I was thinking about like the mental health. and where it would fall. For some reason, I would have thought that mental health would be into mindset, but it falls into the multi complexity. And actually, before we even kind of do so, maybe you should even do a little quick rundown of on those five M's
In
before I.
no particular order. So let's start off with medications. So the biggest thing about medications is that, and the biggest thing in geriatrics is polypharmacy. It's this thorn in our side where our patients are on too many medications, five or more medications, which puts them at risk of drug interactions. It can affect their thinking. It can put them at higher risk of falls. It can, have side effects. And it can increase the risk of hospitalization. So when we're thinking about their medications, for me, whenever my patient comes in with a new complaint, I will blame medications first and foremost. I don't care if it's itching. I don't care if it's hair loss. I don't care if it's um, like I'm not thinking as clearly. Medications are the first thing I will look through, and I will make sure we're not dealing with that to begin with. Okay. And so it's really important that when we're thinking about that component, that's always incorporated into the care plan when you see your patients. So then let's talk about mobility. This is also a big thorn in our side. Falls in my patients. They kill my patients. And it's actually in Wisconsin where I practice. It has the highest death rate related to falls. So we don't fall more in Wisconsin, but we die more when we fall in Wisconsin. So it's really important. It's in Wisconsin, fall prevention is actually life-saving for my patients. And so that's a big thing. So anything that affects my patient's mobility, their ability to get up and move, their ability to stay active, those are things that I'm trying to rectify. The next thing, mind. So mind often, certainly we can think about mental health from a mind perspective, and in some ways it does intersect with like cognition. So if we're thinking about, everyone thinks about dementia and Alzheimer's disease, these things that often occur more likely with age, but also depression, anxiety, those other types of mood disorders often come with it. They can sometimes play together. So we see our patients who have like come in with a memory impairment. One of the things we have to rule out is depression because it can present with something. I think in one of my posts talk about pseudo dementia, where you're not actually suffering from dementia, you're suffering from depression. And if we treat the depression, a lot of the memory problems can improve as well. And then on the other side, we have patients who truly have um, memory impairment and dementia, and that actually can lead our patients to develop more anxiety and depression. And so just making sure mental health wise, cognition wise, we're following our patients. We get a good baseline when we first meet our patients is very important. What matters most. So we're thinking about what matters most. And we kind of talked about goals of care discussions, making sure that our patients do have some type of advanced directive or a plan. It can be regional, the priority in which we would place on that. In some states, they are able to just use their next of kin by default, but in a state like Wisconsin, that's not the case. You must have it written down for medical legal purposes for it to be something that we honor if you aren't able to make decisions for yourself. And it just gives us this roadmap, especially closer to end of life or in critical illness times, where we know what your wishes are. So expressing those and making sure that discussion happens both with your care provider and family so they know your wishes is important. Um, multi-complexity. So we're thinking about multi-complexity. Really, my patients overall are complex. They have, they're in their sixth, seventh, eighth, ninth, 10th decade of life. They've lived all these so many years in these lives, and so many ways in which their lives are different. And so some of my patients need more integrative care, multiple different specialists involved, be it behavioral health, psychology, those kind of things. Do they need to have a more intensive physical therapy program? Do I need to do more rather than me being the primary, but doing more co-management with other specialties if that's the primary reason for their troubles? getting that together, making sure that everyone involved also has a good geriatric understanding or understands that goal of care, going back to that, is very
Have
important.
to,
And then I'm
like we can't try to be for like forever young, but we just have to embrace like like we're getting older, but it's not but we can't try to be always like 20 year olds.
right.
Like we're advancing, like we've known each, like in fact looking back, like you and I have known each other since uh
I probably met you in like 2006 because you lived
oh
in
yeah.
Lister. You lived in Lister.
Yeah.
Okay. Yeah. So I've known you since like 2006.
Yeah,
So
that
that's
was in
like,
2006. Yes.
yeah, 2005, 2006. So
Yeah, it was
like, yeah,
2006.
yeah. So I've known you for a long time.
Yeah.
Like 17 years, maybe. Yeah.
Yep, you've seen me in different yeah, you've seen me in different hair lengths.
Yeah. Hair lengths and styles. Yeah. Yeah. Ageism, it's interesting because people always think about like ageism being like this external thing, but there's a lot of
Uh-huh.
internalized ageism. I hear it every day. My patients, oh,
Mhm.
I'm too old to do that,
No.
or I'm too. And they'll say something like, I'm 70 years old. What do you expect? And I'm like, I don't expect you to be in pain, and I don't
Hmm.
expect you to feel like you can't enjoy life. Like
Hmm.
like I always tell my patients, I was like, I have patients old enough to be your mother.
Yeah, exactly.
Like, so you
I,
aren't like relatively that old. You may be older than like a significant portion of the population, but there are, like we said, there's 50 million other people your age.
exactly. Like
So
that.
like, and I see 70-year-olds with the health, or like, should I say stereotypical health of somebody in their 90s, and I
Hmm.
see 70-year-olds who have the health of like a 50-year-old, a 45-year-old. And so the span of function and health is very broad. So that's when my patient says, I'm 70, what do you expect? I was like, I don't know what to expect, but I don't just expect you to be in poor health. So
Exactly. It's different for everybody. Like Ron Isley. You know,
sure.
Ron Isley, look at him now. He's in his 80s, sounds as great as ever.
Yeah.
Still singing, rocking it as popular as ever. Gladys Knight and Patti LaBelle, both in their 70s, they sound as great as ever.
Yeah.
You know, these two
Yeah.
women are legends. Okay, they sound no great.
Yeah. And it's yeah, it's very interesting. It's very interesting how we think of age and
Exactly.
conceptualize it everywhere around the world. It's so different, it's interesting, and it's something that fascinates me. Uh, so people as a geriatrician, they'll be like, "Oh, so you know all the secrets?" And I was like, "I hope so. I hope that all that I've learned in like in my training will
Uh-huh.
translate to health for me and health for the people around me as we get older, because we don't always know our lifespan, but if I'm going to live that long, I want to live well.
Mm-hmm.
I quantity, if the quantity is there, I want there to be quality with
Yeah.
it. And that's really what I'm shooting for with my patients. If you're still here, let's keep you in the best shape we can.
The other thing that I should address, aside from medication, another is actually a safe alternative that needs to go an entire life in time, and it's actually nutrition. This
Absolutely.
is actually the ultimate, the biggest type of preventative medicine to
Mhm.
address a good lifestyle. And
Absolutely.
that and what do you think is like one of the biggest changes as like you get older, like as as you age?
Yeah. I would say that, so you're absolutely right. Lifestyle is the one thing. So I don't know if there's exact statistics
Mm,
because, like we said, everyone's so variable. But if we look at, I'm going to hazard and say 80% of health conditions that occur can either be prevented or minimized with lifestyle changes, right? And that's not to put the blame on anybody for the diagnosis they have, because things can happen for all reasons. And that's why I didn't say all. 80%. 80% of the time, what we do, what we put in our bodies, how active we are the two things that can make a world of change. I know oftentimes doctors get this bad rep that we always want to push medications, but in our training, changes in diet and nutrition and exercise, first and foremost, be it cholesterol, medication is not first line. Diet and exercise is first line. Diabetes, pre-diabetes, when people's
mm.
numbers are creeping up to that range.
Yeah.
Diet and exercise are the way to prevent you getting there. But once you get there, that diagnosis is a life-changing diagnosis, and we need to take it seriously. And unfortunately, sometimes it requires medications, but even there's many diabetics, type 2 diabetics, who do not need medication. It's diet controlled. We literally call
Hmm.
it diet controlled diabetes. So when we're thinking about those kind of things, so certainly I feel like most people generally who have any understanding of kind of like health and wellness understand that like there are foods that are not great. We know processed foods just generally are not good for us. High
Yes.
salt, high fat, high sugar. These are the foods. I mean, everything in moderation. I am not somebody who believes in elimination diets unless you have like celiac disease or an allergy or some other type of autoimmune condition that makes you completely intolerant, and eating it may actually directly affect your quality of life.
Yeah.
But otherwise, everything's in moderation, because any changes we make to our lifestyle to promote health, it needs to be sustainable. Doing it 1 week is not enough. It has to be to span your lifetime if we're going to make the change. Um, for my patients specifically, nutritionally, the things that I always stress to them is get enough protein. Naturally, as we age, we not lose protein, we lose muscle mass. So even if I'm a very active person, so your yogi putting his legs behind his head, even though he's extremely fit and healthy for his age, his muscle mass still does not compare to him in his 20s. Okay. A 20-year-old yogi and a 60-year-old yogi, even though they're both very healthy, the muscle is different. And
Yeah.
so, and so the older adult needs to take in at least consistently more protein to maintain the muscle they have, because unfortunately, nature causes this like breakdown that's a little bit higher. Even after like 35, our muscles break down quicker than they did prior in life. Okay. So that's one thing, getting enough protein. And many older adults do not. They don't consume enough protein. Oftentimes their appetites decrease with age. And so it's just harder to get what they need. And then the other thing is making sure our patients are getting enough things like calcium and vitamin D and these things that help for bone health. And so, especially women, I mean, men as well, but especially women are more prone to things like osteoporosis. And if they fall, they're more likely to fracture something and have all these issues that then can lead down the line to less physical activity, and then less ability to do the things that we know promote longevity. So those would be kind of a few things. And then the other thing is staying active, walking regularly, getting outside, making sure that more of the day you're spending doing physical activity than sitting. these are the things that I would say in my older adults that do make it to their 80s and 90s. Well, not 80s. 80s is young in my opinion. 90s and above. Those are the patients who are active most of the time. The patients with who have always been active across their lifespan are the ones who generally get there.
Yeah.
And when we think about also patients who get sick, like, I mean, if I'm in my 90s, I may have an illness, something may happen. My patient with more muscle mass, my patient who walks regularly is more likely to recover and actually get closer back to their baseline after, if they recover.
Yeah.
And so there's a lot of important things with that.
Yeah. You know, the just to you were mentioning just a few moments ago an issue with osteoporosis and lack of calcium. Yet I remember years ago when we were told that dairy what could be good for you because it is a source of calcium,
Yeah.
and then now the news are saying that that dairy is bad for you, and now it's and now it feels that the food industry is giving us all these mixed messages in what is good for you. It's now it's like don't all of a sudden it's okay, potatoes are bad for you, and all of a sudden it's carbs are bad for you, breads are bad for you, and wait, those were in the I think the five food groups, and
Yeah. And the
like
Canadian food
what
guide.
are they rewriting? Yeah, in that pyramid.
And the pyramid keeps switching around.
Yeah, like can we get a little consistency, please? It's like you're rewriting, and we are trying to rewriting everything that we're supposed to eat, and every time we're trying to catch up on like what is healthy, like a little
Mm-hmm.
bit of consistency, please, for
So I
everyone.
I would say that even though dairy products are one of the most easiest ways to get your calcium, there are non-dairy foods that provide a substantial amount of calcium, and it really just depends on your dietary restrictions and how you choose to eat. But green leafy veggies, everything pretty much except for lettuce, has a decent amount of calcium. So I mean, if you're plant-based and you're eating greens and greens on greens on greens, you're probably getting enough calcium if you combine that with like almonds and foods like that, greens and beans and almonds and those kind of foods. You very well could get enough calcium. I'm sure there's always all these other calcium rich foods. And then for people who are still meat eaters, things like salmon is a fantastic source. Shrimp and sardines and those kind of things are actually quite a good source of calcium. So certainly people can get it from multiple places. And I think the dairy for multiple reasons is problematic. One is the fact that the dairy industry, most of the time, there's lots of hormones. And I think that's, for me, what I would say would be the most problematic part about dairy. But there are a lot of people who have intolerances, mostly because we're adults drinking the milk for baby animals. And so, like, our bodies aren't necessarily made to consume it. But at the same time, it is a great source of calcium, and um, dairy, if it's not milk, cheese, yogurt, pudding, all of those are fantastic sources for those who can tolerate. I live in Wisconsin, which is dairy country, it's cheese country. So, like most of my patients, that's less of a problem for them. But people who have restrictions, lactose intolerant, and things like that, also considering the plant-based milks can sometimes be reasonable. Almonds are a little controversial. Almond milk is a little controversial because it can be quite wasteful, um, environmentally wise. But there are other veggie milks that can be consumed.
Back in February, I was watching the NAACP Image Awards, and I saw this stunning statistic, and it was saying that only 5%, 5.7% of doctors in the United States are black.
Yeah.
On CNN, it shows that back in 1900, that percentage was 1.3% physician. 1940, 2.8%. And 2023, 5.3%.
Mhm.
If I do my math correctly, that's a what, 4.4% increase in 123
Years.
years.
Uh-huh.
That's really, that's very minimal. That's just about nothing. That, that's
Right.
critically low.
Yeah.
That's alarmingly.
The proportion hasn't increased at all. And then I do see many I guess they call them medfluencers. Sure. Everyone has a name for everything. But like other physicians and other people on social media who practice some type of medical specialty. And the physician's essentially saying, like, let's say I'm a neurosurgeon, like this percent of there's this percent of Black neurosurgeons in the United States. And then I was like, how many Black geriatricians exist? I mean, I think I know of like two others, three others.
Oh
Person.
no, no, please.
But so I actually don't know how many actually exist. And so I started to think about that because it's like probably less than of all physicians, then
mm-hmm.
it's probably less than, I don't know.
Yeah, well,
It's probably in the decimals.
yeah, like
Oh,
it's because I'm looking at this for like three reasons, like representation, opportunities,
yeah.
and diversity.
Yeah. Yeah. So I've always thought, because like I don't work in a place that's particularly diverse. And I mean, luckily my patients actually are overall very, very kind. Um, which is good. But then I also want to make sure that all patients age 65 and above are able to get appropriate geriatric care. And that is something that I I do have a passion for, um, and I would like to pursue that in the future. So yeah, because it's so important that those resources, they're limited, obviously. There's not enough like human resources, but like even with that, that they aren't necessarily concentrated in one place. Like I like trained at Harvard for geriatrics, and it was like there's a geriatrician on every block, right? Like you can find a geriatrician. There's multiple geriatric fellowships in Boston, but then you come to somewhere even like Wisconsin where I am the only geriatrician that works in my whole health system. Okay. And so and so and then you just think about other places where if there's only 7,000 and let's say 500 of them are in Boston, another several hundred are in New York and these major cities, there's so many people who are not having access. Driving 5 hours is not even an option.
If you don't mind me asking, like, what's the, I think what, like the population of, like you're what, it's what's it pronounced again? Like you're central Wisconsin, right?
I'm in central Wisconsin. So the specific place where I live, we have about 20,000 people. But
20,000.
I do have patients who that drive from Michigan like 4 hours, 5 hours to come see me. Um, or
Because they
just,
don't have a geriatrician?
well, partially because they don't have a geriatrician, partially because our health system here is, some people prefer to come to our health system, but like they, I guess, better care in this area. So pretty much it's like my health system, and then there's a few other like more substantial ones in the area, but some of them drive that far because I guess quality wise, they feel it's a little bit higher. So we do have some patients coming usually from Michigan, like kind of the peninsula, which is like right by the top of Wisconsin. It's not that far away.
Yeah.
But I know people in Minnesota usually are going to Mayo and some of those other kind of also very substantial health systems to get care. But in central Wisconsin, most people who truly want geriatric focused care will come to me. But also there really wasn't a geriatrician in the area where I work for all these years. So I don't have a shortage of patients. I think that
Right.
if anything, I have a wait list, and
Oh,
it's unfortunate that
oh my
it's really
God.
like
Yeah,
that.
that,
Yeah.
yeah, like it doesn't, yeah, that, the wait list though, doesn't that get like a little, like too, if you don't mind me asking, like, doesn't that concern you? Because that, oh, for, yeah, for that, for that age group, like,
Yeah, waiting
why
isn't the
wait?
greatest
They
thing.
shouldn't have to wait. Like,
Yeah, I agree. I think it's unfortunate,
yeah,
and this is part of the reason. It's like no time soon are we going to have a good geriatrician to older adult ratio. That's not happening anytime in the next several decades. Like it may never happen. At least it's not going to happen in my lifespan. And that's why making sure that my other colleagues have good geriatric principles that they default to when they take care of these older adults.
yeah,
Or I also make myself open for consultations. If my colleague feels like there's a case where a patient may be more complex than they can currently handle or they need some guidance, I keep my practice open for consultations as well. So I try to be as accessible as possible in my practice. Also, I am an educator as well because we do have internal medicine residents, like I told you, in where I practice the teaching hospital. And I lecture on topics. I lecture on geriatric principles. And my hope is that when they are done training, they've acquired enough of these principles that they can use it when they see their patients. Because yes, uh, I'm not training geriatricians. They don't exist, but I can train internists. I can make sure that these doctors have these background principles when they go into practice. And so that's like a little bit of a way to kind of offset it because at this point, education is going to be the best way for us to be able to kind of help to balance out these issues.
I do have some the three critical questions I gotta ask you.
Oh, yeah.
Now, first of all, what does living your truth mean to you?
I would say that living my truth or just living your truth means you have to understand yourself. And that is a journey. It's something that does not necessarily happen overnight. It may actually change over time because, the same way you get to know someone over time who's not yourself is the same way you get to know yourself. So it comes with your life experiences, but at the end of the day, it's your core values. It's the core things that don't change. It's what, like, when we talk about what matters most, but what matters most to you in life. That's really, if you're able to live based on those as your reference point, for me, I believe that's what I would consider living your truth. So really knowing yourself first and then finding those values is truly what it is.
How does living your truth and being authentic make you a better person?
I feel like living your truth, being authentic, being a better, I'm sorry, living your truth and trying to be authentic, it makes you a better person because it gives you a different perspective when you go into the world. So you're usually going into the world feeling a lot more free than you would because if you're not living your truth, I don't want to say you're living a lie, but like in a way you're not living authentically. And if you think about it, if we just gonna say the complete opposite way, if you're living a lie, then you're spending your life covering up for something, masking something. And so that means that you're never truly able to make authentic connections. Because if somebody accepts you for the facade, then they have not accepted you for who you are. And so I think that you're able to be much freer if you're able to go into the world as yourself because you're going to make more authentic connections, and you're going to be able to find people who align with you, people who are in your corner, and then you can be proud of what you put out there. So, and that's both in your personal life and in your professional life, or any other ways you are.
And finally, what advice would you give to someone looking to embrace themselves?
Okay, so I would say number one, I'd say three things. Number one, know your core values, as I had mentioned before. If you don't know those, then you need to start there. Because if you don't know what matters to you the most, then you don't really have any reference point. And I feel like when none of us know everything and life is a journey, but if you know those things, you can almost always know what the right answer is to the question, or at least the right direction. Number two, surround yourself with people who have those same values as you, and also have people, even though their same values may align with you at those core levels, people who can challenge you to grow. Because stagnation, I would say like with my older adults, sitting is probably is the worst thing you can do for yourself. Get up and move. So that's also how we should move forward in life. And so finding people who can help you to move forward, if it's a mentor or a friend that's not exactly like you, find these people who can help you to have a different perspective. And then number three, be introspective. Look at yourself. Look to see if there's things you can better about yourself, and not from a critical way. Do it from a place of love, right? Do it. Look at the layers as to your why. So why do I do this? Why am I reacting in this way to these situations? Why do I feel like this is a passion of mine? And look through. And so yes, you like might say, I'm doing this because X. But then why are you doing X? And then kind of pulling back those layers, you'll see, you'll think, you'll be able to reveal a lot about yourself if you think about it kind of in this systematic way. Um, so yeah, that's what I would say. Those would be my three pieces of advice.
Words of wisdom from Dr. Aanu Abiola. You can follow her on Instagram and TikTok at Geriatrics Pro Tips. And yeah, she has numerous videos where she educates you, yeah, as a geriatric. Dr. Aanu Abiola, it has been a pleasure having you on Truth Be Told. And thank you so much for being here.
Thank you so much, Pierre, for having me. I really enjoyed the discussion. The questions were fantastic. So take care and please keep well.
Yeah, thank you. And same to you. And to all of you listeners and viewers, thank you so much for watching. And remember, stay true.